Good afternoon and welcome everyone to today's webinar where spiritual care and finance meet, a panel discussion on the intersection of hospital finances and mission and spiritual care. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are all delighted you could join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters at any time by typing your questions into the questions pane of that same control panel. You may send in your questions and we're going to collect these at the end and hope to have a brief Q&A session at the end of today's presentation. I do have some announcements for upcoming webinars at the end of today's presentation, so if you happen to have a smartphone, I've set up QR codes, so you can just photograph the QR code. That'll take you right to the registration page and you'll be good to go. And with that, I'd like to introduce Ben Schaefer, Manager of Spiritual Care for Ascension, Michigan. He's also convener of Transforming Chaplaincy's Spiritual Care Management Network. Ben?
Thank you, Andy. Welcome, everyone. We're so glad you're here with us today. This is a great opportunity for us to continue our conversations around chaplaincy and how we intersect with so many different parts of our health systems. And so we have a wonderful panel together today. I'm really looking forward to hearing more from each of them about their wisdom and their experience working in healthcare and the ways that we can connect with one another. So just to introduce my colleagues here, Marina is our CFO of Ascension Borges, the West Michigan region of Ascension, which consists of 4 hospitals in the Southwest Michigan area. Pam is the manager of CPE and spiritual care at Sinai in LA, and she is joining us from there, bringing the warm weather to those of us in the Midwest. So thank you. And then Ryan is the director of spiritual care at Trinity Health for Michigan, Florida, Georgia, and Ohio. So I'm really grateful to have my colleagues here with me today, and I will be facilitating our conversation. I really encourage you to bring any questions or comments. Please put them in our chat box. We want to make this as dialogical as possible so that we can really continue to be thinking as a group, how do we promote the way that healthcare and spiritual care come together rather than be seen as separate silos. Because I think each one has a great deal of opportunity to support and encourage the ministry and the work that we do each day. And so with that, I am going to just begin with our first question, and we will be working through our questions. And if you want to drop the slides, that's fine. So for each of you, tell us a little bit about how you see your own work in fostering the connection between spiritual care and finance.
I can begin with that. So initially, I think the important part for me to realize was that we're not on different pages, really. We want the same thing. We want quality care for our patients' families. We want to continue a solid business model for our health ministries. And we really want to have a level of accountability for everybody who's working in every ministry and clinical service that's available. So what we've done in varying aspects of Trinity is we began to work with the Catholic Health Association has developed a financial staffing model for spiritual care. We began by looking at that and working with that in order to determine what the best model or what it would look like. And it uses metrics of annual equivalent patient days. And so it uses hard data to determine how you should be staffed in your present healthcare facility. And from there, we worked out the CHA has 4 categories. We wanted to go with your higher ones, which is like comprehensive or established, but that wasn't realistic for us initially, and so we had to rework some of the categories And we've determined that if we could have a minimum staffing category of minimum at the building level, which is that would be okay for a start for a minimum staffing level. And so that's one of the ways we started is really by looking at how could we show what makes sense to spiritual care, to offering good spiritual care, using financial information and patient data information. And so minimum recommended staffing ratio is at through the CHA's pastoral care standard is we have it at 0.06, which is what we found to be the ratio for good staffing within the health system itself, within the brick and mortar health system. But if you want to go outside and expand, then we have to begin a conversation of, well, we're okay staffed for the brick and mortar, but any expansion outside of that is going to require more staffing, i.e. it's a minimum staffing requirement. And we found that finance has been really helpful in those discussions and found this really useful and has always been on our side really in regard to it.
So it sounds like for you, those clear metrics were really important to be able
Yeah.
to begin that conversation.
Yep.
And I'll go next. I would say for Ascension, Borges on the southwest side of Michigan, we are not using metrics regarding spiritual care, but I will say really everything we're doing is really about doing the right thing and making sure that it's patient-centered and it's in the value system every day. And one of the ways that I became involved with Ben is because it's very hard during a global pandemic when so many people are working so hard and there's so many lives that are threatened, et cetera, that to even talk about finance. And so I became involved with Ben closely because I was like, how do we talk about short-term and long-term financial sustainability while also still having that patient focus in that center of care and all the things that you mentioned, Ryan. And so I will say we're not using the metrics, but we are really trying to stay, patient-centered and, quality, safety, and really, I would say talking with individuals and clinical leaders truly about financial stewardship during this hard time with the global pandemic.
Yeah, and I will say for us here at Cedars Sinai, we are fortunate to be a pretty well-resourced department to start with. But what we have realized during the pandemic, and we did an assessment of our spiritual care services throughout our health system, and what we've found is that there is actually a huge need and demand that we were not even aware of. I mean, we were sort of aware of it, but we're very aware of it now. And so now our conversation needs to be how do we, and can we even increase our presence and increase the number of chaplains that we have, especially given these very difficult financial times for all hospitals, as far as I'm aware of. And I think one of the things that is really on the top of my mind is that, as Ryan and Marina have both said, that excellent patient care must include excellent spiritual care. But at the same time, oops, sorry, I just got rid of my panel over here. So, okay, I'll try and get it back when I'm not talking. But the financial side of the hospital has so many competing demands for the limited amount of finances that are available, that we have to be very strategic, and we really have to know what exactly is being looked for in terms of making our appeal for more funding for spiritual care.
Yeah. So when we talk about those ways that they connect and where we're trying to really care for patients holistically, are there some ways that you've seen spiritual care and finance naturally connect over those? Marina, I think you kind of touched on this a little bit in our conversations as we're going through the pandemic, but would you have a kind of concrete example of how you've seen that work for any of your systems or places?
So I'm going to say two things stand out. You know, the first one that stands out to me is like the patient rounding and the patient experience. And I know maybe that doesn't connect finance, but really making sure that we're doing everything excellent for the patient and being involved with spiritual care and the executive leaders at the same time and on the floors and visiting the patients. And then secondly, in our organization, we have what we call part of our hallmark is abide, appreciation, belongingness, inclusivity, diversity, and equity. And we have really, in the finance, we have a finance council that talks about all these hallmarks that bring into our culture and our finances. And we've been able to, again, you know, tough about talking about finances and spiritual care together during this time, especially finances, but really bringing Ben into that conversation with all our finance, not just at a local level, but on a national level as well. So spiritual care is very much part of our everyday life here, whether it's financial or more quality and patient-centered.
And kind of following up off from that, the talk about patient experience. These, patient experience, likelihood to recommend, best colleague care. These are all areas where finance and spiritual care naturally intermesh, because, and that's why a lot of the study and a lot of the research within spiritual care is about, hey, do we have an impact on patient experience? What we're finding is, yeah, we do. Why? Because these are financially important areas. Not just, but what I mean by that is they're financially important because they help us survive and they bring in the money that we need, but also they're important because this is what we want. This is why we exist. We exist to try to give the best possible care to the patients and give them the best possible experience possible. We exist to care for our colleagues, and colleague turnover is an expense. I would much rather care for my colleagues and keep the colleagues that have been there and that I've grown to know and appreciate than lose them because we're not caring for them properly. So this is naturally where finance and spiritual care, I think, just intersect all over the place.
Yeah, I have very little to add to that. I think just to reiterate, and I think in this, the assessment we did of our department services, we had nurses say, patient distress raises staff distress. And our nurses, our social workers, our doctors were very clear at pointing out that even if they can't explain what it is that we do, which by the way, I think is a problem for us, even if they can't explain, they often just feel relieved that a chaplain was there when they know that there was a patient that's really going through a lot or a family that's really struggling. They would say things, just seeing the chaplain's chart note would make them feel better. So we, are working, I think, maybe on opposite sides of the same continuum as finance and spiritual care. We both are wanting exemplary patient-centered care, and we both are wanting to ensure that our staff are supported and engaged and stay with us. And so, yeah, I think our work is intrinsically connected.
We can't do one without the other.
Mm-hmm.
What are some ways that you find challenging conversations between spiritual care and finance, and where those conversations may break down or just have a different language, so aren't able to ships passing in the night, not quite sure how to connect?
I think that this has been a common question, a more raised question than how we are naturally integrated, and that is that we're always opposed. Well, I think there's some opposition in the fact that chaplains are not, well, up until now, have never been a revenue producing part of the healthcare system. And it's also very hard or more difficult to quantify, qualify, and data collect what we do during patient visits, during colleague contacts, and just on a daily basis. You know, we have productivity reports, but those are kind of squishy. We have, you know, we have other kinds of, you know, reports, but there's not a lot of concrete data. So in that, it makes it more difficult to know how many chaplains do we need. You know, if budget cuts are coming, you know, chaplains, you know, that we don't need those, but we need X amount of nurses in order to fill beds. I mean, right now hospitals are crying because they don't have enough nurses to fill beds, and so they can't even make full capacity a lot of times. Chaplains, you know, it's not the same issue. If you don't have enough chaplains, you're still going to fill all your beds. So in those, that's where some of the difficulty I think with spiritual care comes in. Is you know, we all see and can understand the value, but when push comes to shove, it's hard to show that value concretely sometimes. And you know, and through, you know, good quality research, we can't do a double-blind research studies. You know, it's really hard to come up with a chaplaincy double-blind research study. So we have a lot of case studies. We have a lot of more, you know, non-concrete research that I think is effective and makes sense and promotes spiritual care, but it's not as concrete as some of the others. I think that along the lines, and the other is a lot of places have us as administrative staff and not clinical staff. And so when administrative cuts come down the line, first place they look maybe chaplaincy, because, you know, again, oh, you're administrative, you're not clinical. And so, you know, arguing and defending that we are clinical and that, you know, we are essential to patient care, sometimes it's more difficult.
You know, and I'll just add, Ben, I thought this was a very hard question you just asked, so it took me a minute. But first of all, I'll just say something, you know, Pam, when you mentioned, you know, sometimes they see at opposing ends. Here, I would say at working with Ben, I don't really feel like anything is opposing. I feel like it's a continuum of care. So I think we're really fortunate to have that. But I will say, I can give an example of one time that there was a disconnect. We were kind of ahead of the curve, and I don't think we ever really knew it. But, you know, spiritual care had come and they had asked for money, you know, for videos and to be offering 24-hour virtual care, and for ethicists too, for 24-hour care. And I, you know, when it was presented to me, I thought, wow, this is an expense we're going to have that other ministries are not going to have. And I really had to think about, but in a way, I'm so glad I said, yeah, well, I'm very glad I said yes, but it was really partnering with the innovation that they were bringing, not knowing we were about to enter a pandemic and it would be so well needed. You know, so I will say that was an example where, you know, I had to look and just say, what is the right thing? And it was the right thing to do. And fortunately, with innovation and ideas that, you know, our individuals are able to think creatively, we were able to really work collaboratively with them and fund this. And we were ahead of the curve, and it's worked out well.
Yeah, thank you, Marina, and thank you for bringing that back and correcting me, because even as I said it, I was like, that came out kind of wrong. I didn't mean we were opposed opposed to each other, but that we have the same goal in mind. We're just working it from different angles.
Absolutely.
Yeah, but I appreciate you bringing that back, because I did also kind of raise my own internal eyebrow as I said that. You know, I think for me, some of the biggest challenges have come up with language. And I think, Ryan, you mentioned that. I personally know very few chaplains who come from a finance or business background. And so for us to be able to describe what we do, describe what we need in a language that makes sense to people in the financial world can be a stretch, and I will include myself in that. That is not one of my great strengths. And I would say the times I've been somewhat successful is when I've had someone who could do that translation and help me with that. I remember one time when I was reporting to the chief nursing officer who had an MBA, and I was trying to explain what I wanted, and she's like, this isn't making any sense. And then finally I managed to explain, and she drew this beautiful diagram, and she said, this is how we're going to do this. Because once she understood what I was asking for, she said, well, here it is. This is how we lay it out, and boom, we got a position. So that was a good lesson to me of like, we've got to learn to speak this language, and we can't be expecting. Marina, I can hear you're lovely and very open to these ideas. I wish everyone was, but but we can't expect that. I think we have to learn how can we bring our message. And I think different people, what I have found in different institutions I've worked in is that different people are looking for different ways of explaining it, or perhaps different data that makes an impact on them personally. So it's not even like here's a one and done. If you do this, this will get the message across. Is what I have taken away. But that, for instance, I have had a recent time that didn't work. I didn't get the funding that we're looking for. But what I did get from it was, oh, this is what they're looking for. So now I need to go and get that data and then come back with that data. But anyway, I think that was one of the things. And then also, as Ryan said, being a non-income generating part of the healthcare institution, it does seem that spiritual care is very quick to go on the chopping block when, or the cutting block, maybe not necessarily the chopping block, but when budget cuts are needed. Although I have found everywhere I've been that people are actually very aware of the value that chaplains bring. But I think there are pieces that we need to be able to talk about. For instance, even though we don't generate income, that the places where we can save income, most people when they describe it, what it is that we do, they describe end-of-life care and specific religious rituals. But chaplains are also really helpful in dealing with things such as length of stay, adherence to plan of care, mitigation of staff distress and staff turnover. And as Ryan was pointing out, those are things that can actually save a hospital a lot of money. So we have to learn to be able to put that into a language that can be heard and understood. And we also need to be able to clearly describe what we do and that it is in line with and supportive of the mission and the values and the goals of the institutions we're in.
So, Pamela, I think you bring up a very good point about how do you bring your case and really have it understood by all languages. So I will tell you here at Ascension, we use a lot with the SBAR, where it's kind of a one-page executive summary, and it doesn't have to be one page. I always say one page, usually not many people make it to one page, but right, the situation, the background, the approach, and the recommendation. So what I usually do when people come to me with the idea is I ask them to put that in their own words, put it in that type of format. And then once it's in that format, then to bring it to me, and then we can add the numbers and look at that and how it makes sense by working together. But I will say that is very helpful because I think of a lot of the individuals in spiritual care and the clinical leaders that I work with, that's how they see it. So it's letting them get everything for their perspective, and then we add the numbers.
Well, I think that, Pam, following up on what you were saying, and then Marina as well, what you were just saying is language is so important. And, and the SBAR does work really well because, I know as I was creating the SBAR, it helped me to just have to go through that process in order to better understand what I was asking for. And then the language to help other people understand it. I may understand something in my head, but how am I going to make other people understand what I'm asking for and why this is a good idea? I think that's the other thing is I can tell you about, any number of things, but why is it, and say why it's a good idea in my own head, but conveying that and helping others to understand that. And I don't, so I don't think that it's necessarily a finance issue as much as, like, say, a language issue, and making sure that when we're conveying what we need, we're doing it in a way that other people can hear, understand, and so then we can work together to make the best decision.
So as you three have been talking about this a lot, the two things I keep hearing come up are communication and data metrics, and that these two things really tie together importantly and connect the way we communicate and work together. And there are a few questions that have come up in the chat that I think really relate to this. And so here's two of them. One says, how does one quantify the work of chaplains? What are some of those metrics that we listen to? That's a slippery kind of amorphous thing for many of us in spiritual care. But are there one or two things that you like to listen for or really focus in on? And then the second one on that is, has anyone figured out a way to really sum up in a short spiel the way spiritual care can affect length of stay? So those were the two that were there with that. Easy questions, I know.
Yeah.
Well, I'll jump in with the metric that I have recently found quite important. I think that it is important for us to keep track of what it is that we're doing. I think that it is important for our administrators to know that we're being productive in what it is that we're doing. It is also important to be able to put into that certain types of patients and certain types of visits will take more time and will be more time intensive in terms of interdisciplinary collaboration, as well as working directly with the patient. So that is the one thing. But I think on the other hand, one of the things I've also found very helpful was kind of counterintuitive at first, which is to collect the data on what are the referrals we're not getting to. Who are we not able to get to see? And that data actually has ended up being very persuasive in a couple of cases recently, when finance had to make some tough decisions about, where is this money going to go? So for us to be able to say, this is the percentage of patients who are either getting discharged or in some cases sadly dying before the chaplain was able to get there and there was a request had been made. Because that again, I think goes really to the heart of the patient-centered care if we're not able to get there. But that won't go very far if we're not able to show how productive we are actually being as well.
So some of the areas of productivity that have become, we can show how many patients we've seen through our EMRs pretty easily. We can even show how much time we spent with them. We can show a number of that. But in the pandemic, one of the big things is staff care. We increased our hours and our time of staff care exponentially, and we've never had really a good way to document that. How do you document staff care since you're not documenting it into a data collection area? And so as of right now, we're moving forward with a pilot project in a couple of our facilities to promote some documentation around staff care, and it's very simple documentation using a QR code, and we don't give any information because we want it all to be confidential, private, and no one be able to track it back to whoever in anything, because we want to hold the staff and the colleagues as highly confidential, anything that they share with us. But that's an area that we're working on in trying to pilot, because that's a lot of what we do now. It's a good portion of where we're headed and what we're doing is that colleague care. It's kind of basically moving into a corporate chaplaincy type thing, because if you're caring for staff and you're caring for colleagues, you're caring for patients, as well. And then beyond that, in regard to research, in regard to very different areas, staff retention is an important one, and then patient stays, that would be another important one. I know that there is some research out there, but I haven't. It's not coming to my head exactly where those articles are at this point in time. But I have seen them come through in the near future. I can't speak directly to that. I know another area that we're looking at is 30-day readmission rates, 30-day readmissions, and seeing if we can have an impact on reducing 30-day readmissions of those high-risk patients. So,
I would say, boy, those are great questions too. How do we measure spiritual care and, you know, how do we measure the impact that spiritual care has had on the service? But it's very interesting because I will say I'm an accountant and I probably can come up with a whole lot of measurements on all of these things for us. And I almost want to do it now that the question's been raised. But I will say, you know, here at our ministry, spiritual care is so much the foundational cornerstone of everything we exist on. It's kind of like it starts here and it all built on top. And, you know, once a year I'm in meetings and the entire spiritual care comes and they report out, and I'm in, you know, other meetings regarding the programs, you know, of our virtual care and other things. But I will tell you that regularly it's something that people celebrate here, the spiritual care. I live it and see it when I, like I said, on the patient rounding and the experiences. I see it when they come into the board meetings and they bless the physicians with the healing of the hand ceremony. It's so much an underlying value. But I am going to look at the metrics, and I think there's a great opportunity really for finance to share our initiatives with spiritual care and see how we can be more integrated, because I do believe there is a direct correlation that we would see positive outcomes and say, wow, this is really something we did. So maybe next year I will have those metrics and be able to show the improvement. But thank you for that good question.
That is very exciting, Marina. Sorry, Ben.
No, go ahead. And so, you know, Marina, you get really excited about the data, the metrics, and also seeing spiritual care as integrated. So this question is a little bit more directed toward you. How would you help, or how would you encourage us as chaplains to kind of share that excitement with some of our CFOs who may be a little less excited or thinking about spiritual care, but might be just focusing on the hard numbers?
Yeah, I think it would be great for finance to share with spiritual care what our financial initiatives are, and listen, really connect with you and listen to how you think you can help. You know, I see it in the daily interaction, and there are some things that are just priceless. And I'm going to bring up an example of, like, Ascension uses the value-based decision-making guide that spiritual care came up. It's when you have hard decisions to make. You know, they're not easy, right? But it takes you through like a flow chart of like 7 questions to ask yourself in the whole group that's making the decision. So I think that those are things that I think we can bring. That's something spiritual care brings to finance that I think is invaluable, because it really makes us recenter ourselves and think, is everyone, like, I'll just use, you know, do we have all the input from all the stakeholders, not just one area of stakeholders, but do we have input from all of them? Have we looked at all the alternative solutions? You know, does this decision we're making match our values and principles? So for someone who runs very fast here, it makes me have to sit back, recenter, and ask myself those questions that kind of confirm that we're making the right decision. I was on one call, I don't know, probably about a week ago, that really everyone walked away and said, you know, we have to rethink this and come back. And I just think those do impact finance. It just, again, it hasn't been measured, but I think it does. So, but I would like to, then I'll share our financial initiatives with you and we can work on this together. But financial stewardship, it's just really tough. Like I said, during this pandemic, to bring up, to be talking about finances when we're talking about lives, it just was very tough. And I think that spiritual care is just really working with them hand in hand helped us do that gracefully.
Thank you for that. I really do think that the more we can communicate, the more we can talk between spiritual care and finance, the more we see those ways that we work together rather than being opposed to one another. I'm intrigued to see, and this will be a whole nother webinar that we'll, I'm sure, have in the future, but with CMS now recognizing spiritual care as billable, what is that going to look like? How is that going to affect our careers and our profession and the way that we do this? I'm very intrigued to see how that goes, and whether that changes these conversations and how it changes these conversations. I know the other thing for within Ascension with this is that we were able to get chaplains classified as clinical staff, and that went hand in hand with that CMS ruling, that if we're billable, we're also clinical. So I'm hoping to see that continues as a wave across our profession across the country. But there's still no clarity on what that looks like. I don't think the people who were involved in the CMS ruling have any idea what it means yet either. But hopefully more to come on that.
Yeah.
Yes, other thoughts on that, CMS or clinical? If not, we will go on to this question's for Pam and Ryan primarily. What would you like to communicate or connect with finance leaders to help them understand ways to improve collaboration from your perspective and your side of things? If you just were able to sit down and have coffee or take them out to lunch, what were the things that you would want to really communicate that you think would be most helpful in improving that dialogue?
I think we've touched on it already, but just the not the lack of the desire, but some difficulty with data collection on certain areas of ministry, and in what we do, that like I say, the EMR is one thing, getting data from that is pretty easy and all of this, but at the same point in time, going deeper into the EMR, DMERIC created a whole measurement for productivity of chaplains that worked for him that worked at Mayo Clinic for a while. But at the same point, that was very it took a whole lot of effort, and it's very difficult to say how many chaplains do you need per patient bed, how many there have been a number of attempts at trying, some say 100, well, but then you get ICU beds, and then you get ED traumas, and then you get, how many outpatient beds, how many, and as chaplaincy expands, it becomes even more difficult because, you got cancer center chaplains. Well, how many cancer center chaplains do you need per, a cancer center of what size? So just, understanding that it's not for lack of want, at times, but it's in what I already heard here is there's the possibility of maybe partnering. We can come up with a way forward that could give us some more solid ideas on how to measure and collect what would be useful and helpful for everybody.
Yeah, and I know I jokingly said at the beginning when we were talking prior to this webinar starting that I would just simply say I agree. But I agree wholeheartedly with what you've just said, Ryan. I think the only thing I can add to that is, as an educator, I've watched my own kind of journey through, learning to interact and put my case or the case of the department to the financial department. And I will say from at the beginning, when I first started as a chaplain, I was working in an institution that went through a very, very difficult, oh gosh, what was it? We had consultants come in and really like chop and downsize and it massive cuts and layoffs. And spiritual care was seemed to be at the front of the line all the time, but somehow we managed to like just slip out of the way. We didn't have any cuts, but nobody got a raise for about 5 years at all, not even cost of living. So it was really, really challenging, and that kind of made me see finance as like the bad guys. They're out to get us. And then I was fortunate enough to work in a small community hospital where the CFO involved everybody. We had a joint commissioner visit coming, and everybody had to be involved in preparing. And I really got to see the other side of things and what the finance team was facing and that bigger picture. And that generated a lot of empathy. Marina, I never want to do your job, ever.
No, it's hard. But it's interesting. I thought, boy, what would they talk about if we had lunch? But I will tell you what I would talk about with you is I just think in such a time where so many of our clinical leaders have had burnout and the staffing shortages, you know, whether that's physician, whether it's nurses, I mean, it just seems like it's all over. And I just think spiritual care has just done a phenomenal job of really, you know, the sessions that they put on, that they offer to people, even though it's optional. You know, I just think, you know, if you had to measure these, I can't imagine I would think the measurement in the HR realm and physician, you know, physician or clinician well-being is just phenomenal of what everyone in your field has really brought to us. So, you know, thank you for that, because really it's something that we don't measure, but I'm sure if we did and we start to, we would see that it's just been invaluable. I mean, these are individuals that didn't, you know, I mean, everyone works to have joy in their work, and it's hard to do during these times. So what you've offered in terms of that, you know, having us recenter and refocus is invaluable.
And focus on the work that we all do together to provide good care for our patients and their loved ones and the associates.
And I think being able to understand what it is that each other are doing is what I'm hearing as well.
Yeah, when there's so many different, you know, terms or phrases or shortcuts that we have within our own kind of focus, it gets hard when we're trying to communicate across those.
Mm-hmm.
So the term no mission, no margin, no mission gets thrown around a lot. And I think that there's some value to it. I think it gets overused. But what would you do when you think about that phrase? What things are helpful for it? What things are kind of a misnomer that aren't helpful when discussing how we work together to provide good care?
Boy, you know, I'll probably address that, because that no margin, no mission, it just seems to come out of finance individuals' mouths more often. But it's tough, right? When you make decisions and you fill out that SBAR, you know, I would say you want to be looking short term, but you also want to be looking long term. And you want to, I think what Ryan said, it really is making you focus on what you want, but that value add, if you can put the frosting on it, if you have that value add, that really helps us. And I will say also, you know, sometimes, you know, when individuals talk about margin and we talk about where we are, and some of these maybe are, you know, permanent changes to healthcare right now or in the near future. So I always think sometimes you have to take a step back to step forward. You know, if the margins aren't there, we have to step back and really think it out and maybe go, you know, have less to be able to have more at a future state. That's how I personally think about it. And but I will say, if you can try to add value when you come with a proposition or proposal, that would be helpful. And I think the three areas that I would ask everyone to think about after you have your information and, you know, your proposal in play is think about, it seems like where things are is we're all thinking about how does it impact the people. You know, that's where a lot of people are looking at savings as people. And so, you know, think about, did I make the decision right with the people I'm in this proposal? The process, is there a more efficient process that can be used? And then technology, have we leveraged technology? It's a big thing that's starting to go on now, where it seems like those are the three areas for savings that people are finding at this point: people, process, and technology. So I'm going to say no mission, no margin. Boy, I kind of don't like hearing that, but I do understand it's, you know, we want to be here for the short term, but we also have to be here for the long term and make the, you know, the right decisions for financial stewardship that lets us be there in the long term.
I like what you have mentioned there about value, and that you put value in more than financial means. I think that sometimes no mission, no margin, or no margin, no mission gets solely categorized in oh, we don't have the money right now, and it's used kind of flippantly. And for, you know, for a situation where we may not want to really discuss it in depth, and so we're just gonna throw it out. I think I totally agree with it if it's meant in in the true way that, yes, if you're not making what you need to be making to exist, you're not going to be in existence for very long. That said, when we're talking about bigger corporations, there can be a ministry that's not making money and not making money for a long period of time, but is of significant value that they keep it going because they're a big enough company that they can take it on. That it's specifically caring for a population that it's essential to care for, and to not do it would be ethically problematic or not just not right to do. So in that situation, in specific circumstances, yes, we can, places can exist without making the margin, but as a whole, the company has to at some point in time, or else they're not going to be able to exist for very long. So I agree with it in that respect. I just don't like it when it's used as kind of a cop-out for not listening or hearing. But I really liked what you said in regard to value, that there's other ways to measure value too within a company, that financially it may cause us to be take an initial hit, but in the long term it might be actually better. And so when I'm talking finance, I got to remember, okay, I do have to show some value here. I just can't be asking for 5 more chaplains without showing why, what value is this going to bring to the corporation, because the company does have to make wise decisions based on good stewardship.
Yeah, and I would just echo that. I think we wouldn't exist if the organization couldn't stay afloat. Then we wouldn't exist. We wouldn't be able to do the mission that we have, and so it is very important. And then on the other hand, I love the word putting in value there. The way I would think about it is, how do we determine what is a worthy investment, even when it may not really seem as though it's making direct financial sense at that particular time? Can we see where it's going, that it's worth investing in, because this is something that's important? Which, Marina, going back to why I said I wouldn't want your job, because I imagine you're making that decision and everybody thinks what they're asking for is a worthy investment, and how you determine all of those, I think is very, very difficult. Yeah, so it's always a balance.
We each bring our own strengths to the work that we do, for sure. So we're going to turn now to a few of our questions that our colleagues have put in our chat. And for those of you who are listening here, please continue to add questions. I want to make sure that we have time here to engage them all. So this one here is, I'm a one-person department chaplain, and I was furloughed during the pandemic. After I returned, the CNO told me that they had a decision to make. They would not make it until after they saw how I facilitated communication with patients, families using technology when in-person visits were not allowed. My question now is, I am approaching retirement. How can I build the case for our for-profit hospital to rehire a full-time chaplain after I'm no longer here? I fear they will use it to make it a volunteer position using local clergy, as smaller hospitals have done. Thanks for any advice.
I think that highlights something that we actually haven't touched on yet, and that is the value of board certification and the value of proper clinical pastoral education for chaplains. And that sometimes gets undermined. And right here, the issue is that, oh, well, any pastor will do. I mean, and the problem is that, we are board certified chaplains go through a lot of clinical training and a lot of specialized training in order to be the best at what we do. And pastors are trained completely differently. Pastors do not have that clinical training. They are trained to care for their own people. They are not trained to care for anyone regardless of faith, tradition, religious background, history, you name it, and care for people of many and all religious faiths to the best of our ability. So that would be, my starting point would be, okay, what are they going to lose? They're going to lose the ability to ensure that everyone is cared for with a professionalism and high clinical care ability. They're going, and they're going to lose the staff care that we all do, because calling in a pastor from the community, they're not doing staff care. They don't know the staff. Staff aren't going to come to them. Part of the reason that makes that chaplains are often really good at staff care is because they have relationships with the staff and the staff trust them, and that's going to be lost. So I would start from a position of, okay, what are you going to lose and what are you going to gain, and then go into what are you going to gain, to show that this is not a financially reasonable move, because for say $60,000 a year, basically when you add all the benefits packaged in, you're around $130,000 a year or something like that. I'm sure somebody could give a better number than me, but you're going to be losing, staff possibilities of staff retention, quality patient experience, and quality patient care across the board, and in any number of other opportunities throughout the ministry. So.
And the piece I would throw in there also is the interdisciplinary collaboration and how trained chaplains really can facilitate the care of a patient through the information that they get from that patient and passing it on to the team that makes the care much more effective. And that is completely lost. And oftentimes, unfortunately, with untrained community clergy, you might find them actually hindering the work, unintentionally, I'm very sure, but perhaps even hindering the work that the staff are doing. So not only is it not the best care, but it can sometimes be risky.
The thing I was thinking of too is, I don't know if there's a way to look at other funding sources, either through the donations or, as Ben mentioned, the billable, the CMS making things billable now. Maybe it helps offset the numbers that help out too. It's very tough. It's very tough in these times. It's no doubt, but I do like the ideas that you both mentioned.
And I think the only other thing I would add to that is there is a lot of data out there and research that has talked about how spiritual care impacts the patient's care, whether that be reduction in length of stay, whether that be in the way that patients perceive and trust their healthcare team and are more willing to work with them on making those difficult decisions. Those are some places that pulling some of that data into the business case for continuing to have a chaplain at a site like that can really be an opportunity to name those things and put some evidence base behind it. So it's not just the stories, because our cost avoidance, our cost savings is important, but that's a much harder thing to prove than all the other pieces. And so if we can show the value added, really gives us that opportunity to name that more. Another question here is, how do you factor in CPE, educator positions and students into thinking about staffing and making the business case?
Well, for me, I feel like this is like, of course. So I think, especially for hospitals that have an educational mission, I think having a CPE program really fits in with that as well. I think we have to be very, very careful, and I'm speaking from California, where there are a lot of laws about students and what students can be used for, and so we really do need to say that students should never be taking the place of staff. But certainly students can be adding tremendously to the patient care. And I think some of the places where they add is that we get a lot of diversity with our students that is just not possible to get with our staff. And of course, the diversity, kind of comes and goes with the students, but they bring a very fresh perspective. What our staff chaplains say all the time is that having students around them who are learning, who are asking questions, kind of keeps them on their toes and keeps them fresh with what they're doing. And so it's actually very inspiring for the staff to be able to have students around. And then, as I said, the piece about the diversity of religious backgrounds, cultural backgrounds, languages spoken adds tremendously to the patient care that's given, particularly if one is in an area where there is a lot of diversity. And I know I can speak to that coming from West Los Angeles area. But if anyone else wants to add to that, feel free to jump in.
Yeah, so I'll add to. I totally agree with. I think there's a whole lot of benefit to CP programs. CP programs, they continue to develop even the staff chaplains. And I think that it's important, as you said, Pam, to realize that they should never supplant a spiritual care program. It shouldn't be the only spiritual care program that exists in any facility, because I think that in doing so, the students as well as the chaplains miss out on huge opportunities to continue to grow. We all talk about being continuous students. Well, this is a way that all staff chaplains continue to grow and hone their skills. When you got to train somebody, when you got to mentor somebody, you've got to be up on your skills. You've got to be up on what you're doing. Whether that be charting or documentation or direct patient care or patient at bedside. So I think that, CPE programs offer a huge amount of value. And they also can help staffing. Like you say, there's a whole lot of rules and regulations around student usage and things like that we always have to be aware of. But at the same point in time, they can take a unit and they can in their training, they can go and see the patients on that unit. They can learn, and the spiritual care that they're offering is usually a very high quality value. And so I think that, I'm all for CP programs in the fact that I think that they're, their value far exceeds their cost.
I think just to add in what you were saying, Ryan, is they enable the staff chaplains to work at the top of their license. So yeah, and so that you get more out of your staff chaplains as well when you have a CPE program. So yeah,
That's a great way to put it. Thank you.
That is great. Thank you so much. We're almost at our time, and so we want to end with our last couple slides here, and if you don't mind pulling those up. If this conversation has kind of piqued your interest and you want to dig more into this, there are a number of opportunities to continue growing, learning, developing. And one of those is the Transforming Chaplaincy Certificate in Spiritual Care Management and Leadership. It's a really great program. Pam and I are both graduates of that program, and really helps in thinking about how do we connect the spiritual care work that we do with all the other aspects within the hospital, and how do we think through doing that well. And so there's a QR code there if you're wanting to look into that more. It's an excellent program, begins in January. And a couple more webinars that are coming here in the coming weeks. Friday, December 2nd, Best Practices in Telesupervision. Should be a very interesting webinar. And then another one coming up on December 9th, Spiritual Care for Nursing Home Residents with Dementia. And thinking about how do we care for patients as we look more and more at the aging of our population. We're going to have more and more dementia, and how do we care for those patients in respectful and caring ways? So once again, thank you so much for taking the time to be a part of us. Thank you to our wonderful panel discussing team and the way that we had this conversation. We really appreciate you taking the time to join us, and we hope you have a wonderful afternoon. And for those of you in the US who are celebrating Thanksgiving next week, enjoy that as well. Thank you for joining us.
Thank you.